Hello, and welcome to this week's Ethical Dilemma in Science, where we examine the ethical impact of science and technology on society. I'm Professor John Hoffman, and today I want you to imagine an organ working tirelessly inside you right now, filtering your blood, creating essential proteins, and even storing vital nutrients. It's one of the most crucial organs in your body, performing over 500 functions every single day. Yet despite this incredible capabilities, it's also at the heart of some of medicine's most profound ethical dilemmas. We're talking about the liver. This vital organ, often overshadowed by the heart or the brain, performs an astonishing array of tasks necessary for your survival. But what happens when this powerhouse fails? In the not-so-distant past, liver failure was a virtual death sentence. Today, thanks to medical advancements, we have the option of a liver transplant, a procedure that saves thousands of lives annually. But this medical miracle brings us face to face with uncomfortable questions. With a persistent shortage of donor organs, how do we decide who receives this life-saving gift? Should everyone, regardless of the cause of their liver disease, have equal access to transplantation? And what ethical tightropes must we walk when a healthy person offers a part of their liver to save another? In this video, we're going to take a look at how does our liver function and what happens when it fails? What options are available for liver transplants? And finally, what factors should be considered when deciding who gets a liver when there aren't enough to go around? Understanding the liver's role is absolutely critical for appreciating the weight of these decisions. Located in your upper abdomen, typically weighing around 3 pounds, about 1.36 kilograms, the liver is the largest solid organ in their body. It's the body's primary detoxification center, filtering your entire blood supply roughly once every minute to remove toxins, waste products, and harmful substances like drugs and alcohol. It's a metabolic powerhouse, regulating blood sugar, producing bile essential for digestion, and synthesizing vital proteins like albumin and clotting factors. It even stores essential vitamins and minerals. When this vital organ is compromised by disease, conditions like fatty liver disease, hepatitis, or cirrhosis, the consequences are severe and wide-ranging. End-stage liver disease can lead to debilitating symptoms, and without intervention is often fatal. This is where liver transplantation enters the picture, transforming a terminal diagnosis into a chance at renewed life. The stakes couldn't be higher. On one side, you have a patient facing imminent death from liver failure. On the other, a scarce resource, a healthy donor liver, either from a deceased individual or a living donor, capable of saving that life. The framework for navigating this is the complex world of medical ethics, where principles like fairness, autonomy, and beneficence collide with the harsh reality of limited resources. We must understand who needs a transplant, what the procedure involves, the historical context of its development, its prevalence, and perhaps most importantly, why these procedures, despite their success, force us to confront fundamental questions about fairness, responsibility, and the value of human life. As science continues its remarkable march forward, pushing the boundaries of what's medically possible, we are increasingly forced to ask ourselves, what are our ethical responsibility when the gifts of science are not available to all who need them? This is the critical challenge we explore today. To fully grasp the significance of liver transplantation, we first need a deeper appreciation for the organ itself. The liver is a reddish-brown, wedge-shaped organ nestled between the diaphragm and above the digestive organs. It consists of major lobes, the larger right lobe and the smaller left lobe, and is often described as having 4 lobes, including the caudate and the quadrate. Internally, it's a marvel of microarchitecture, organized into thousands of tiny functional units called lobules. Within these lobules reside specialized cells called hepatocytes, liver cells, the primary metabolic workers. A particularly fascinating aspect of the liver's anatomy is its unique dual blood supply. Unlike most organs that receive only oxygenated blood, the liver gets about 25% of its supply from the hepatic artery, carrying oxygen-rich blood directly from the heart. The remaining and larger portion, about 75%, comes from the hepatic portal vein, bringing nutrient-rich blood directly from the stomach and intestines. This arrangement allows the liver to immediately process absorbed nutrients and filter substances from the digestive tract before they enter the general circulation. It also holds a substantial volume of blood, about 13% of the body's total supply at any given time. Perhaps the liver's most remarkable characteristic is in its regenerative capacity. A healthy liver can regenerate even after significant damage, potentially recovering its full size within months if up to 70% is removed. This astonishing ability is what makes living donor liver transplantation even possible, where a portion of a healthy person's liver is transplanted and both the donor's and the recipient's livers regrow. However, this regenerative capacity is not unlimited. Chronic damage can lead to permanent scarring and failure. The journey from understanding the liver's basic function to achieving successful transplantation was a long and challenging one. Before the 1960s, liver failure meant certain death. The concept of replacing a failing organ was audacious. The first human liver transplant was attempted by Dr. Thomas E. Starzl in Denver, Colorado on May 5, 1963. While the surgery itself was performed, the recipient sadly died 3 weeks later from complications. Initial attempts faced significant hurdles, including surgical complexities and the body's rejection of the foreign organ. Recognizing these challenges, Dr. Starzl temporarily paused his transplant program to focus on crucial research. This period of dedicated study led to advancements in surgical techniques and critically breakthroughs in post-operative care and immunosuppressive therapy. The introduction of powerful immunosuppressants like cyclosporin in the 1980s was a game changer, dramatically improving survival rates. 1 year, survival rates, which were around 33% in the 1970s, jumped to 70% by the early 1980s. These hard-won victories laid the groundwork for liver transplantation to become the established, life-saving procedure it is today. The need for liver transplants is driven by various liver diseases. While historically viral hepatitis was a predominant cause, the landscape has shifted significantly in recent years. According to data from 2022, alcohol-associated liver disease now accounts for the largest percentage of liver transplants in the United States, at 38.6%. Closely following is metabolic dysfunction-associated steatohepatitis, often linked to obesity and diabetes, accounting for another 18.8% of liver transplants. Other causes include chronic hepatitis and genetic disorders. Liver disease typically progresses through stages, beginning with inflammation and potentially leading to irreversible scarring known as cirrhosis. Once cirrhosis is severe enough to cause end-stage liver disease, characterized by symptoms like jaundice is associated with the yellowing of skin eyes, ascites, which is a fluid in the abdomen, and cognitive impairment, transplantation often becomes the only definitive treatment. The impact of transplantation is undeniable. In 2022, a record 9,527 liver transplants were performed in the United States, representing a significant increase of 52% over the past decade. The procedure boasts remarkable success rates, with approximately 75% of recipients surviving 5 years or longer. These statistics highlight the power of medical science to restore health and extend lives. However, these positive numbers tell only part of the story. Despite the increasing number of transplants, the demand for donor organs continues to exceed the supply. As of the end of 2022, 10,548 adults remained on the U.S. liver transplant waiting list. This significant organ shortage, created the stark reality that not everyone who needs a transplant will receive one. This scarcity is the fundamental driver of the ethical challenges we must face. The demographics of transplant recipients also raise important questions about access and equity. In 2022, adults comprised the vast majority of recipients at about 94.5%, with the higher proportion being male, about 61.9%. By ethnicity, white individuals represented 68.8% of the recipients, followed by Hispanic at 18.1%, Black at 6.9%, and Asian at 4.4%. While these statistics are complex and influenced by many factors, they prompt necessary discussions about ensuring equitable access to transplantation across different communities. Furthermore, the increasing practice of living donor liver transplantation, where a portion of a healthy donor's liver is used, adds another layer of complexity. In 2022, 6.3% of transplants came from living donors. While living donor liver transplants offers a crucial alternative in the face of organ scarcity, it inherently involves risk to the healthy individual who receives no direct medical benefit. This tension between potentially saving a life and potentially harming a healthy donor is a core ethical consideration in living donor liver transplants. The most debated ethical challenge often revolves around patients with alcoholic liver disease, or ADL. Given that ADL, alcoholic liver disease, is now the leading indication for liver transplantation, this is a critical issue. Traditionally, many transplant centers implemented a 6-month rule requiring patients with alcoholic liver disease to demonstrate a period of sobriety, often 6 months, before being considered for transplantation. Proponents of this approach argue that with a severe shortage of donor organs, allocation decisions must prioritize those most likely to have long-term success and avoid relapse. They contend that transplanting a liver into someone who might resume drinking risks wasting a precious life-saving resource that could have gone to a patient whose liver disease was not behavioral in origin. To be sure, ensuring a recipient's commitment for post-transplant health is a valid concern, particularly when organs are scarce. Allocation systems like the Model for End-Stage Liver Disease, or MELD score, used in the United States, is a numerical system used to assess the severity of liver patients and to prioritize patients for liver transplantation. It already prioritizes medical urgency, but the argument is made that behavioral factors should also weigh in when the cause is linked to addiction. But nevertheless, a powerful counterargument exists. Opponents of strict exclusions or waiting periods for alcoholic liver disease patients argue that denying life-saving treatment based on the origin of disease is discriminatory and constitutes inappropriate moral judgment. They emphasize that addiction is a recognized medical condition and treating alcoholic liver disease differently from other diseases, like those caused by viruses or genetics, is unfair. Furthermore, patients with severe alcoholic hepatitis often have acute liver failure and cannot survive a 6-month waiting period. Recent studies have challenged the necessity of the 6-month rule, suggesting that carefully selected patients with severe alcoholic hepatitis can achieve post-transplant outcomes comparable to patients with non-alcohol-related liver diseases, even without a mandatory waiting period. This evidence suggests that denying transplantation based solely on the cause of disease might be both ethically questionable and potentially medically unnecessary in some cases. Living donor transplantation adds another complex ethical layer. While it helps mitigate the organ shortage, it places a healthy person at risk. Should the ethical principles guiding deceased donor allocation, which treats organs as a societal resource, apply equally to living donation, which involves a direct personal choice by the donor? There is also the tension between a potential living donor's desire for information about the recipient's condition, including behavioral history and relapse risk, and the recipient's right to privacy protected by HIPAA. This conflict pits donor autonomy against recipient confidentiality. The liver's journey from being an organ whose functions were once poorly understood to becoming the subject of routine, life-saving transplantation is a testament to scientific progress. We have achieved remarkable feats that were unimaginable just decades ago. But this expansion of medical capability is inextricably linked to an expansion of our ethical responsibilities. The decisions we make about organ allocation, recipient selection, and the role of living donors are not merely medical judgments. They are reflections of our deeper societal values concerning fairness, autonomy, and the inherent worth of human life. As scientists and physicians continue to refine liver disease treatments and transplantation techniques, we must actively engage in thoughtful dialogue about these ethical dimensions. Simply relying on medical criteria like the MELD score is insufficient when faced with such profound moral questions. By examining complex issues such as the transplantation of patients with alcoholic liver disease or the ethical considerations of living donation from multiple perspectives, acknowledging the concerns about scarce resources while upholding principles of justice and compassion, we can strive to develop approaches that honor both scientific advancement and human dignity. The liver, with its astonishing ability to regenerate and heal, perhaps offers a metaphor for how we too must continually evaluate and regenerate our own ethical frameworks as medicine progresses. The intersection of cutting-edge medical science with profound ethical questions is often where our most important societal conversations need to happen. How we choose to answer these questions about the liver's paradox, who gets a second chance at life when we recognize that not everyone can, will ultimately reflect the kind of society we aspire to be. So what do you think? I'd love to hear your thoughts. Consider these questions drawn from the complex landscape of liver transplantation ethics. Should patients with alcoholic liver disease have equal access to transplantation compared to those with non-behavioral causes, especially given the scarcity of donor organs? When considering a living donor liver transplant, should potential donors receive full information about the recipient's condition, including the cause of their liver disease and potential relapse risk, even if it might compromise the recipient's privacy? Given the persistent organ shortage, how should allocation systems balance medical urgency, likelihood of long-term success, and factors potentially perceived as related to personal responsibility for the disease? How can we ensure equitable access to liver transplantation across different demographic groups and socioeconomic backgrounds? And finally, what is society's responsibility to individuals suffering from end-stage liver disease, particularly when the primary treatment option is limited by organ availability? Share your thoughts below in the comments. If you found this discussion valuable, please like and subscribe and share this video to keep this vital conversation going. Thank you for joining me today. Until next time, keep thinking critically about the science that shapes our world and the ethics that guide our decisions.